our presentation.
Thank you, Ed. Next slide, please. Before we continue, we would like to address a small disclaimer that this presentation was prepared for the MHTTC network on the cooperative agreement from the Substance Abuse and Mental Health Services Administration. All materials appearing in this presentation, except that make directly from copyright sources, is in the public domain and may be reproduced or copied without permission of SAMHSA or the authors. Citation of the source is appreciated. Do not produce or distribute this presentation for a fee without specific written authorization from the MHTTC Network Coordinating Office. This presentation will be recorded and posted in our website. At the time of the presentation, Eleanor Mackenzie-Katz serves as SAMHSA Assistant Secretary. The opinions expressed herein are in the views of the speaker and do not reflect the official position of the Department of Health and Human Services, or SAMHSA. No official support or endorsement of the DHHS or SAMHSA for the opinions described or this presentation is intended or should be inferred. Next slide, please. Like I mentioned, today we'll be having Dr. Marianela Rodriguez Reynaldo, who is a clinical psychologist certified in perinatal mental health specialist, postpartum doula, and certified lactation educator. Without any furthermore, Dr. Marianela, thank you.
Thank you, Angel, and thank you to the National and Latino MHTTC Network for the invitation. I'm very grateful to be here, and to all the participants who are interested in this subject. I have been working with this population and this topic of perinatal mood and anxiety disorders for the past 10+ years. So I'm very excited to share some of my experiences and hopefully to introduce to some of you a little bit more about this topic and the concepts related to it and how to best support Latinx communities. So with that in mind, these are some of my objectives for the next hour. We're going to be talking about the different concepts that are related to this topic, as well as the importance of increasing awareness into the general public and mental health professionals regarding this topic. And hopefully at the end, I will give you some resources and spark an interest in this, in perinatal mood and anxiety disorders and where to look for help, and also refer your clients if the need be. So these are some of the relevant concepts I want to talk about: antenatal and prenatal. So when we talk about that, is any time before birth or during pregnancy. Also perinatal and peripartum period. The DSM talks about the peripartum specifier. So that means the peri means any time around birth, is that period immediately before and after birth, but also has been defined to include from the 20th week of gestation up to 4 weeks postpartum. Then there's the postpartum period, you know, that we are 9 months pregnant and the rest of our lives we're postpartum. So it's any time after birth, but it has been medically defined as the 6 weeks after birth. Also in the literature with psychology and mental health, it talks about the first year after birth. So that this is when all these mood disorders can occur within that 1 year after birth, and it's still considered the postpartum period. Also in the literature, you can find the first 1,000 days. This is more of a perspective focused on the nutrition and the care and development of conception up to 2 years after birth of that baby. And it's considered a critical period for the foundation of that development. So when you add up the 9 months approximately, plus the 2 years after birth, those are the first 1,000 days of the human being. And they're very important in terms of development and wellness. And then our topic today, which is going to be the perinatal mood and anxiety disorders. This is a concept that it's come to introduce the rest of the disorders that can happen around this time period. For a long time, we've only talked about postpartum depression and sometimes even just postpartum, and we leave it at that. But it's important to recognize there's other disorders that can happen, and it's part of the awareness that we should be talking about. So I was glad to see that most of you knew that this is not a new concept. Perinatal mental health has been around for a long time. We can date it back to Hippocrates, who in 400 BC talked about the wandering uterus and thought that the liquids or the fluids that come out of the uterus after birth can go up to our brain and result in mania or deliriums, even postpartum. So it's dated that far. Also in the mid-19th century, Dr. Esquirol and Dr. Marseille, we have specific case presentation of psychiatric illnesses during the postpartum period and lactation. And Dr. James Hamilton in 1960s wrote one of the first books specifically with psychiatric illnesses within this period. And he also founded the Marseille Society that is still active. And it's an organization that unites investigators and researchers interested in this area. It actually had its annual conference virtual, of course, last month. So it's still very active, and it has a chapter, the North American Marseille Society chapter. But however, it's important to know that it wasn't until 1994 that the DSM-4 introduced the postpartum specifier under the major depression disorder as a specifier. And then now in 2015, that is the current DSM that we have. When the revision happened in 2015, they opened it up a little bit more on the peripartum specifier. So it includes what we know from the literature, that these symptoms and these disorders can occur during pregnancy and during that first year postpartum. It's still a ways to go to include more of the concepts and the disorders that actually do happen within this period and the DSM still. But we've gained some good field there. So why is this important? Well, postpartum depression is the most common complication affecting women after childbirth. Which is interesting because we usually focus on the physical aspects and talk about all the complications that can happen, but really don't focus or don't educate enough on the mental well-being and all the changes that occur in terms of emotionally. The non-psychotic mental disorders are also a common comorbidity of pregnancy and the postpartum period. And suicide is a leading cause of death in postpartum women. It's not the leading, but it's within the first causes of death. And that's interesting because a lot of states are not mandated to report that. So that could be underestimated, and we might not know the relationship between that, the suicides and the postpartum death causes. PMADs also, this is a very important issue because it has adverse effects, we know, on mothers, fathers, on the diet interaction, as well as infant outcomes and their development. So it's a public health issue that we need to look at for detection and treatment. We know that up to 1 in 5 women will suffer from a mental health disorder like postpartum depression. So those are pretty big numbers. And also interesting is that less than 15% will receive treatment. So a lot of these women will go untreated. And that has also an effect on her wellness as well as the development of the baby, the family, and society as a whole. 1 in 7 will experience depression during pregnancy. And a lot of the times this goes unnoticed as part of the normal changes in pregnancy, which shouldn't be, and that shouldn't be seen as the normal process of pregnancy being depressed. And up to 50% of women living in poverty will suffer from a maternal mental health disorder. So we see the relationship in disparities and social health determinants with these kinds of disorders. And it just doesn't happen only to mom, but it affects the family as well, and as well as partners, dads, or non-gestational parents that can develop symptoms, sometimes 1 in 10 will experience perinatal mental health disorders. And that could go up if the mom has a disorder as well. So important numbers to remember. Within our Hispanic and Latinx community, we already know that there's a lifetime prevalence of depression in Hispanics, and it could be as high as 12% more than found in the general population. Hispanic women have higher rates of depression than non-Hispanic women, but are less likely to be identified as depressed. And the prevalence of depressive symptoms in pregnant Latinas in the United States and Mexico can be higher, and up to 32% in pregnant Latinas and 36% with Mexicans. This is a survey that was done nationally and specifically in California when looked into the Latinx community more in depth, focus on their maternity care. This is some of the results of what Latinx said. 5% identified that they were treated unfairly during their hospital stay because of their race or ethnicity. 7% reported that they felt medical staff did not communicate well with them, and 10% felt that medical staff did not support them during labor. 80% said they believed that the childbirth should not be interfered with unless medically necessary, compared to 66% of white women. So it's important to know where our client is coming from and the experiences that they're having in childbirth. Regarding their mental health, 13% of Latinx screened positive for depression, while 22% screened positive for anxiety during pregnancy. These numbers change somewhat, and 6% of Latinx screened positive for depression and 8% for anxiety during the postpartum period. Now, this can be for many reasons, and we're going to talk about that a little bit. And one of those can be the barriers that are found regarding talking about emotional, like depression, emotional symptoms during the postpartum period, and what that means to this community. Nearly 20% of Latinx reported they never had someone to turn to for emotional or practical support after giving birth, compared to approximately 5% of white women. So this is very significant, especially if we know that Latinx might, they need someone, or as anyone else, to get emotional support and who to talk to. So the conclusion of these surveys pretty much was that Latinas are not receiving the healthcare or the non-medical support they need to thrive before, during, and after childbirth. We add COVID to that, and what do we see? We have that Hispanic and Latinx women, pregnant women have higher rates of COVID by September 2020 than any other of their counterpart groups. So puts them at higher risk and higher vulnerability to develop some of these disorders and additional stressors. So let's talk about why this period is unique. This is a new emerging concept, and it's called reproductive identity. And I think it's very important that we talk about this with our clients in our practices. And it has to do with how a person self-identifies when it comes to experiences related to the question of if, when, and how to have children. I think for a long time, it was given that if you're born with a uterus and if you're a woman, this is what you should be doing, having kids, and there was no question regarding of what you wanted to do or if you wanted children or not. And that, I think, it's specifically true with our Hispanic and Latinx culture. Where that's part of the sometimes rigid gender constructs of this is what we should be doing, this is our purpose, to have children and to reproduce. And we now know we're questioning this, and or maybe we have for a long time, but now it's more open and more available for that questioning. And this is something that we should be talking about in practice with our clients. I mean, the odds that even if you don't work with the reproductive area specifically with your clients, the odds that at some point one of your clients becomes pregnant or thinks about this or brings this up, it's very high. So it's important to be able to talk about it and be supportive regarding the questions that they might have. Also, interesting concepts, not as new. And it comes from an anthropological term called matrescence or patrescence, which sounds a lot like adolescence because it has to do with the changes of the body, mind, and hormone shifts that happen that are comparable to what happens in the adolescent periods, may also happen during motherhood and fatherhood, you know, when we become parents. And all those changes, there's somewhat normal and expectancy of it that is important to understand. And I always want to bring this up because I'm going to talk about disorders, but not all the ambiguity or uncertainties or feelings that may come up during this time have to do with a disorder. We can't pathologize motherhood. That's not the point. But it's to be aware that there are symptoms that could become a difficult situation to deal with for the parents. But there's also the normal shift that comes with motherhood and becoming a parent, especially for the first time. And, you know, the proponents of what matrescence is also propose that we understand and we study and we educate providers and professionals and the general public on this topic and understand these changes, just like we do to understand the changes in adolescence. And with that, also related to that change in roles, it's what's called liminality, which is the quality of ambiguity or disorientation that occurs in the middle stage of a rite of passage. So being pregnant and becoming pregnant when it's a time of liminality, where you don't know where you're at, are you a mom or dad yet? Or do we wait until the baby's born? And what does that mean in the Latinx culture? It's also important to understand, and how the perspective of our client regarding this, what is it regarding this time period? It's important also to acknowledge that when a baby's born, parents are also born, and it's a new identity that we assume with all that means. Pregnancy is a time of crisis, a time of transition, of vulnerability, and a lot of introspection. So it's an ideal time for psychotherapy. I'm one who thinks that we should all go through therapy when we're pregnant because the changes are so big, you know, and it's such a good time to do introspective work. We imagine our babies, we imagine ourselves as mothers, as parents, we imagine our partners if they're around and how that's going to be. We go back to our history and understand our mother roles. Who were our mothers, our significant mother roles in our lives, and what does that mean, and what does that mean to us? And a lot of women are very clear on what they don't want to be like, or what they do want to be like, and how all of that is an ideal period to process and understand all these changes and transition. And that comes full of preconceived ideas and expectations. The media is constantly telling us, as far as our culture and the expectations of what mothers should be like, especially in the Latinx community, where the gender roles are a little bit more rigid and strict, and what motherhood should look like, and what are the roles that we should assume, and who's to take care, really, and how we are from the beginning getting ready to be mothers as children, right? So we have a lot of expectations and preconceived ideas of motherhood, of what conception is going to be like. We know infertility rates are pretty high, and a lot of the general public don't know about that. They think I'll stop the pill and immediately I'll get pregnant. And what happens when they don't? What happens when they can't conceive or they have difficulties? And what does that mean to their image and to their identity? We have a lot of expectations about pregnancy and what a pregnant woman should look like and who should take care of her, and the role she plays in society as a pregnant woman and how is she treated. regarding her culture. The same as birth. There's a lot of fear about birth. We know in the movies and in the media, birth is portrayed as a very painful, out of control process, that it's not up to the woman, but up to the providers who take care of her and tell her and guide her what to do. So it's a lot of expectations and sometimes myths and unrealistic ideas of what birth should be like, which also can produce a lot of fear. And it's important to talk about that and be able to open that up. The same as the postpartum period. And we're, so we're full of what this should look like, and then reality doesn't match up with all the expectation of that postpartum period, where I should be totally in love with my baby, and some women are not, may not be immediately in love with their baby. And what does that mean to them, and who can they tell, and who can they talk to about these feelings that may not be in line with what culture is saying that it should be. Also with body image. I have a picture here of Serena, which I think she's beautiful, but she also had a lot of, she had a very traumatic birth, and her life was in danger during her birth process. I invite you to look at that if you haven't seen it, and what that means, and how that raised a lot of questions also about maternal mortality in the United States, and especially among African American women. So body image, it could be very altered. We can have a lot of expectations. Not a lot of us are familiar with what a postpartum body looks like. And, the media portrays these celebrities who look look better after birth than they did before they were pregnant. And then we look at our bodies and we question, what is that and how does that look like? And the same with the pressure with the Latinx, the body issue, and what Latinas moms should be doing and what they should look like, and especially in this pandemic. And while we're in the house and the things, just mothering is not what we expected, and how we're breaking our own rules with this pandemic. I think it's very interesting because, we might just be giving the phones to our little kids. It's what we can do in these times, and they're all connected, and that's not what we expected, and how specifically I thought motherhood was going to be like, and how this pandemic has altered all of that. I think these are very important topics that we need to be discussing and opening it up to our clients, where they can talk about how they feel with the changes they've had to make, especially during this pandemic and the lockdowns. In terms of Latinx community, there's a commonly practiced tradition in Mexico and other Latin American countries that's called cuarentena, and that is where the new mother is expected to do nothing but take care of herself and the baby, especially for a period of 40 days, or those first 6 weeks. That is that medical time when we need to really take care of our bodies. It is believed and considered that the mother's body is vulnerable or open, and to protect herself, she must cover her head and neck with garments and wrap her abdomen in a cloth called faja, or the girdle. And a lot of hospitals, specifically in Mexico, you can get discharged with your faja already because it's needed. And it's important to understand this from that cultural perspective, and specifically again with this pandemic, and when there are families who are immigrants and they don't have their support network with them. It's important to understand that, and to understand how the expectations of they were going to take care of me, and now I have no one to take care of me, and I'm all alone with my baby at the house, and there's a pandemic outside, and where to go and what to do with all that. There's also myths about fathers and non-gestational parents, especially, again, with our Latinx community. Fathers may be seen as not needed while babies are newborn. They play a secondary role to mothers in the raising of young children. It may be thought of that the father's primary role in the family unit is to be the main financial breadwinner. They might be thought of as strong, robust, and can fix anything, and that they do not have emotional needs, and that they're less nurturing, gentle, and protective of their children than mothers, and that a man's life doesn't greatly change when he becomes a father. And that's a lot of sometimes resented by the gestational parent, and thinking like his life didn't change as much, just mine changed. And that's not necessarily true. The truth is that men can get perinatal anxiety and depression as well. And as I said before, the risk is higher if the gestational parent develops symptoms. So it's important to bring them in when they're available. And if you're seeing your client in counseling, bring in the partners. Talk to them about their feelings and will. Give them some space, because they might not have them in their culture, in their family, or in their surroundings, and they might not want to bother their partner with what they are feeling. So it's important that we as providers are taking care of the partners as well, and having them educated on what to look for with the mothers. So what are some of the barriers when seeking treatment? Mental health treatment specifically. So Lara Sinisomo has done a lot of work with the Latinx community, and she identified 3 structural barriers when seeking mental health treatment for this community. One is the structural, that has to do with provider unavailability. Language as a barrier. We know we express ourselves better in our primary native tongue, and sometimes if we can't find a Spanish-speaking counselor, it would be harder. Lack of information about services as well. We don't know where to go. There's instrumental barriers that have to do with insurance coverage, transportation, or lack of childcare. I think that's very important. And if we're going to see families in this period, in perinatal period, we should have our offices prepared for that, to accommodate moms with their children, and moms or women with other older children and family that can come with them and take care of the baby. And we also want to see, we need to have a space where there's they can feel comfortable changing a diaper or coming in with a stroller. So we also need to accommodate our office space to provide for that. There's also barriers of social barriers for mental health seeking treatment, like stigma, preferences for family. We know that. Lack of awareness about these symptoms and these disorders, and concerns about safety or lack of trust. And from one of her studies in 2014, she highlighted the importance that Latinx communities, specifically regarding prenatal and postpartum mental health treatment, they prefer family and friends in helping them cope before going to a provider. And when they do go to a provider, we really need to build that trust where they can feel safe to talk about how they really are feeling and what that means, and not think that we are, one of the biggest fears is that we're going to remove the baby because they're not a fit mother or they're not doing well. And that's really important to get that out and be clear on what our role is. So there's other general barriers when we talk about perinatal mood and anxiety disorders, because this is such a loaded topic, the motherhood situation. There's a lot of denial and fear and silence around it. Women do not voluntarily express how they feel because a lot of times fear of being judged or of their babies taken away or depending their migratory status, what they could fear, and the stigma surrounding not only mental health, but motherhood as well. And professionals might not be asking. They might not be asking because they don't think it's their area of expertise, or they don't see the importance, or they think it's just going to go away, some of the symptoms. Or some of the symptoms may overlap with symptoms related to pregnancy, like fatigue, or just that vulnerability that we talked about before. And also, we know that our healthcare system is fragmented, so they might see a specialist for like an OBGYN, but not necessarily that OBGYN works with a multidisciplinary team that includes counseling and psychotherapy, or that screening for mental well-being. These are other barriers that have been found with specifically Latinx women regarding mental health. And it's the stigma, not knowing where to find care, lack of transportation, low health literacy, cultural and linguistic differences like we talked about, and documentation fears. It's important that we understand some of the Latinx cultural norms, always taking into consideration that as a group, we might have some shared values and norms. We always need to assess the individual as they are, and do not assume. Always ask where they are with these cultural norms. Typically, familism is one of the cultural norms that's very prevalent in the Latinx community, and it's about that family comes first, and things get resolved within the family. We talk about it in here, in our group, in our close nucleus, but not outside. Marianismo is another cultural value that's very important, and it talks about describing the woman's ability to self-sacrifice and suffer for the sake of the family. So that mother identity is a lot of times compared to like a mysticism of the Virgin Mary. She gives it all for her family, her babies, and her needs come second, come third, come fourth. They come at all. So sometimes they might not feel like they can talk about what they are feeling, or the questions they might have, or ambiguities they might feel regarding motherhood. And then parenting practices, that authoritarian strategies and firm control as a value, and just being strong, that schema of a little bit of a superwoman, feeling strong, and you know, that baby's not going to make me feel so vulnerable because I have to be so strong and authoritarian all the time. Also, we have to take into consideration what mothering looks like in a different land, and the acculturation level for our clients. We also need to understand some idioms of distress that are common to Latinx. Nervous is one, which are related to feelings of anxiety and sadness. And they may perceive these as normal during the postpartum period and not seek help at all, because they think that's part of just being postpartum and have given birth. So they might feel all this stuff and it's just going to go away on their own. Also susto, which is attributed to a frightening event. It could be related, I mean, there could be trauma after birth, but they think also that it's not, that's just part of having gone through birth and through that experience, and not reported as something that might need a little bit more support to go through it. And that is experience. The susto includes feelings of sadness, poor self-image, and a lot of somatic symptoms. So we need to be in tune with that and understand that. Also, mal de ojo, or the evil eye. This is typically understood with the vulnerability of the children, and the children being very vulnerable to envy or that evil eye, and that can make them sick. So a lot of Hispanic and Latinx community protect their children by buying them an azabache, which is like a black stone and they put it around their crib or on them in a bracelet, and to help them scare away that evil eye. So that's important things to understand and take into consideration when we're talking about motherhood and this time with our clients. So let's get into what perinatal mood and anxiety disorders are. So this is more of an umbrella term to include all the different disorders that could be related to this period specifically. It's important to keep in mind that they can be present before or during pregnancy and up to 12 months after birth. So why do they happen? What we know is there's usually a combination of factors. There might be some persons or some women that have biological vulnerabilities, and they could be more sensitive to hormonal changes. We know the thyroid has some changes during pregnancy and postpartum, and that needs to be ruled out. It's very important. Others might have psychological factors that could be there as a previous diagnosis or personality traits. We know social determinants are related, like racism and social or lack of social support, and all the expectations that we just talked about and the stigma, that all could be related, and it's usually a combination of these factors. First, I want to talk about baby blues. Baby blues can happen up to 80% of women may experience that, and the symptoms are transient and they resolve without the need of intervention. They include tearfulness, irritability. It's more like a premenstrual syndrome kind of feeling. They're unrelated to stress or psychiatric history, and they may last up to 2 weeks. And the importance here is that this is not a disorder, that these are the reactions typically to all the hormonal changes that happen after birth. Depression, as we know, for the DSM-5, and in order to diagnose it, we need 5 or more of these symptoms present for the period of 2 weeks. And we know the symptoms, they include depression and lack of motivation or interest, changes in weight and sleep disturbance, fatigue. It could also be combined with anxiety and fear and excessive guilt. And what we want to determine here is, are these symptoms in excess of what is experienced by most new mothers? And are the symptoms considerably different from the woman's usual level of functioning? And we want to assess if the symptoms persist even when they are less likely to be explained by the demands of new parenthood. And that should give us a sense whether we're talking about major distress or the baby blues. And we want to also assess it and understand the frequency, duration, and intensity of the symptoms. So it looks very, very different when there is distress. And it's a problem when it's a problem for our client also. We need to be clear on that to understand it. We need to be really in tune with what she's saying. She might not come out just because she doesn't know and say she's depressed or anxious, but she might say, I'm not cut out to be a mother. My thoughts scare me. I feel like my baby does not love me. I feel out of control. I don't feel like myself. I'm a bad mother. I'm so tired, I can't think straight. My baby would be better off without me, or I feel like I'm going crazy. So if we hear her say these things, we need to explore a little bit further. And what does that mean for her? Important facts that we want to know about postpartum depression is that Latinx are 37% more likely to experience it than any other group. That postpartum depression can occur after birth of any child, not just the first, which is typically a myth that we have, that it only happens to first-time parents. That at least 33% of women who have had postpartum depression have a recurrence of symptoms after subsequent deliveries. That if untreated, postpartum depression can become chronic, and that 60% have onset of symptoms within the first 6 weeks postpartum. And about 25 to 50% of women with some anxiety disorder also show symptoms of postpartum depression 2 months after childbirth. What are some risk factors that we need to look at and that have been related in the literature to the development of postpartum symptoms is when there's history of alcohol use, and there are perinatal losses that have occurred in the past, the age, the adolescence, and interpartner violence. When women who are single have a higher risk of developing postpartum depression, when there's a history of depression, when there are economic difficulties, when there's a type A traits, personality, and when there's lack of support. We need to be specifically attentive to that. And what is the impact of untreated depression? We know it's been related to low birth weight, developmental delay in the baby, incomplete immunization schedules, acute or chronic diarrhea, somatic symptoms, and disrupted sleep patterns and child abuse. It's important to mention that this is the impact of untreated depression. So it's very treatable, and that's the importance of identifying it in time. It's also been related to practices of breastfeeding, and women tend to breastfeed less or stop breastfeeding earlier than women who do not suffer from postpartum depression. So when we talk about anxiety, anxiety during the prenatal period can be very common. Some of the risk factors are very similar to the depression, and it could be as high as 21 to 25% in the prenatal period and up to 8 to 20% in the postpartum period. We look at the general anxiety disorders and the panic disorder, pretty much a similar presentation of when they're not of people who are not pregnant or postpartum, but always also that anxiety and that worry related to the baby. And I think that's what's unique with this population. There's a constant worry about several things, fear of consequences and ability to cope, and a lot of physical manifestations on both, on the general anxiety disorder and the panic. As we know, when we experience anxiety, we overestimate the danger and underestimate our skills to cope with that danger. So a lot of feeling that fear that they are out of control, the fear that they're going to die. It's very prevalent with this population. I remember working with a mom specifically who would fear that another panic attack would come and she would faint and she would leave the baby all alone. And that was her main worry. What happens to the baby if I have a heart attack? So it's that fear of fear and fear of another panic attack coming in. The impact of untreated anxiety also, we have seen that during pregnancy are related to fetal heart rate and motor activity, preterm delivery, and difficult infant behavior. Postpartum anxiety is related to lower maternal self-confidence, and parents can be oversensitive or overreactive. And this kind of causes a vicious circle where the parent is overreactive and oversensitive to the baby, and then the baby perceives that, and it tends to be a little bit more active and hyperactive. And what that does, it's like a vicious circle with the parents, and may increase family conflict. Another common disorder in this period that's prevalent is OCD. We know OCD has to do with obsessions, which are intrusive thoughts or images that are very disturbing, and compulsions are behaviors that a person must engage in order to neutralize those obsessions. These are very scary, intrusive thoughts that happen to pregnant and postpartum women, usually related to contamination of the baby or illness of the baby. It's a wonderful book by Karen Kleiman. It's called Good Moms Have Scary Thoughts. I invite you to look at that. It's very good for us providers, but also for parents to understand. The reality is that all of us as parents have scary thoughts at some point, but when we have OCD, they become, they impact our functioning. There are 7 categories that have been identified in the postpartum women regarding OCD, and these are thoughts of suffocation, that the baby's going to suffocate or it's going to have some accidents, ideas of intentional harm, thoughts of losing the baby or the baby having a complicated illness, unacceptable sexual thoughts, and that of contamination. And it's very important to tell our clients that they are not their thoughts and that what they're feeling are symptoms of a condition, because it's really disturbing and distressing for the parents who are living with OCD. PTSD, postpartum stress disorder, which happens when a person experiences or witnesses the actual or perceived threat or death of a serious injury of herself or another. So this can happen a lot of times during birth, but also with the partners witnessing the birth. And as we know in DSM-5, there are specific criteria. There needs to be the stressor that causes significant distress or impairment, and it must be present for 1 month after the event. And it should include intrusions, memories of the trauma, flashbacks and nightmares, and that physical reactivity, avoidance, which include emotional numbing, denial, social withdrawal, negative cognitions such as guilt and sense of blame, and a hypervigilance also present. Some perinatal traumatic events include disrespect and abuse during childbirth, undergoing unnecessary and extensive interventions, lacerations, episiotomy, forceps, having a baby in the NICU, experiencing a stillbirth. Being sick throughout the entire pregnancy can be very traumatic. I remember working with a client who said, just motherhood is not for me. If I have another baby, I'm adopting. So she knew she'd never wanted to go through pregnancy or birth ever again. Poor response to anesthesia. There's a lot of cases that we know of where the anesthesia doesn't quite take and the woman feels the procedures and it's like a cesarean. Poor lack of informed consent during labor or feeling coerced, and separation from newborn. So we know some of these experiences may have heightened with COVID and the different protocols and the changing protocols. We know that in some states, women were asked to give birth alone, and they were not let partners come in, and they had to be by themselves, and they were separated from their newborns, and how they're experiencing all that within this new context we're living. It's important. The impact of untreated PTSD can be significant and long-lasting for women, and these are some of the things that can happen. They can avoid postpartum care. It may define her identity, whereas they can see themselves that they couldn't give the birth, they couldn't do the birth they wanted, so the implications that has on their identity as a mother. It could interfere with breastfeeding and bonding, may impact sexuality. They may avoid future pregnancy. It can disrupt close relationship, and the baby may serve as a reminder of the trauma and may impact the partner who witnessed the events. I really like this picture because I think it portrays a lot of what sometimes women with PTSD hear as they try to speak their story, and a lot of people just say, at least you have a healthy baby. And especially with this, with our Latinx community, where they feel they have to sacrifice, and that's all part of being a good mother. So what does that mean when they have traumatic births? And who do they speak about that when we have to do everything and sacrifice everything for the birth of our babies and for the baby's health? Other serious conditions include bipolar disorders and psychosis. Psychosis is one of the most dangerous, and it's a medical emergency, but it happens 1 or 2 in 1,000 postpartum women, so it doesn't happen as often as the other disorders that I just talked about. And as we know, psychosis has to do with disorganized thoughts, impaired thought content, and may need hospitalization and medication. With bipolar disorders, we know a lot of the times women are taking off their medications during pregnancy and not given any other alternatives to take care of their conditions while pregnant. So that serves as a trigger when the postpartum period comes in. So these are 2 serious conditions that need specific attention. A lot of with bipolar disorder as well can go unnoticed unless we take a thorough intake interview where we know that history and understand the trends or the changes that a woman may have had in their emotional condition. So finally, some of other experiences that need to be assessed with this population is interpartner violence. Like I mentioned, it's the incidence of interpartner violence is higher during pregnancy and may put the women in danger and limit her alternatives of looking for help. Infertility, perinatal loss, the NICU experience, which can be very traumatic for parents. The history of sexual trauma, we need to look at that and understand it because birth can be a trigger of that sexual trauma that happened in the past. Breastfeeding, we need to understand the intention and her interest of breastfeeding and the type of feeding method that she prefers. It's very important, and it's important to respect that, given all the information. There is a syndrome that's called dysphoric milk ejection reflex. This is a physiological condition, and I invite you to look into it. It's called, there's a site, it's called demer.org, and you can find more information on that. And it's when women report that they feel anger or sadness and irritability, especially when the letdown occurs as they breastfeed, and it can last for a couple of minutes and then it goes away on their own. And it's important that they understand things they can do about that. Also, we need to look at the relationship, a lot of how it impacts having a baby, the relationship. We know it impacts, and we need to be able to talk about that and bring the partners in. Sexuality, substance use during this period. And also I just want to say that eating disorders, it's a lot, often not identified, but pregnancy can be a trigger for people who suffer from eating disorders. So how can we help women and families when they don't know what's wrong? And how can we reduce stigma and normalize the new mother's need for support? We need to be able to screen, educate, and take action. In terms of screening, we know the American College of Gynecologists, the ACOG, as well as the American Academy of Pediatrics, both have statements and have released statements on screening and the importance of screening. And OBGYNs should be screening their patients at least once during the prenatal period with standardized, validated tools. And they need to provide treatment options and follow-ups, as well as the pediatricians. Even though the baby is their patient, they should be screening at 1, 2, 4, and 6 month well-child visits, because we know that the infant will do better when the mom is better, and that diet relationship will be better. Also, the U.S. Preventive Service Task Force has provided specific recommendations that women who present any of these risk factors, being single, adolescent, with low socioeconomic status, or have a previous history of mental health treatment, or have results between 5 and 10 in the Edinburgh or the PHQ-9, which are two standardized screening tools, they should be referred to counseling. So these are the screening tools that have been validated in Spanish as well. The one that's mostly used is the Edinburgh Postnatal Depression Scale because it is short, simple, and it's free and accessible, and has been validated in many languages, been thoroughly used in Spanish. The postpartum depression screening scale also is in Spanish, but it's a little bit longer. It's got 35 items. So it might it's just be a little bit, it's not used as much as the Edinburgh postnatal depression scale. The Woolley questions include just 2 basic questions that we can ask during the past month. Have you often been bothered by feeling down, depressed, or hopeless? Or during the past month, have you been bothered by little interest or pleasure doing things? Yes to one or both of these questions requires further evaluation, and no might be a negative test and not required. We want to be careful with this if we do not have already an established trust with our client, especially Latinx, because they might just say, yeah, sure, or no. And we need to go a little bit further with our screening and our questions to make sure. We want to ask. Like I said before, the woman will probably not come out and say how she feels, especially if there's feelings that she's considered negative with her culture and her family values. So we need to ask her, how are you feeling? How was your birth? How can I help you? How do you spend the day with your baby? And how was your birth experience? These are questions that need to be asked, and we need to be able to provide that safe space where she can talk about this. We cannot assume that perinatal mood and anxiety disorders can be identified just by looking. We have a keen eye, clinical eye. However, women may look very well, they may look very attached to their children and still not feel well, because they're just doing it in automatic and doing what they're supposed to be doing. So we want to educate all our clients and family regarding maternal mental health awareness. We want to create a safe and comfortable environment for conversation. We want to ask, we want to tell them that we ask all parents because we understand that parenthood can be challenging, especially in these times. So we want to ask how they're doing. We want to normalize PMADs in our conversations, avoid judgment, reduce fear of disclosure, encourage small action steps, and support mother-baby bonding by seeing them. Be culturally sensitive and know your resources in your community. You should be able to know, and I'm going to give you some of what groups are out there for new parents, for breastfeeding, for support when there's a loss, a perinatal loss. And take action and offer treatment. So treatment includes psychoeducation in all of these things and understanding what that means. Therapy should be the first line of service and treatment for this population, and also the referral of social and community support. And there might be a need for medication as well, and we need to know in our resources who are our psychiatric reproductive psychiatrists in the area that we can refer to, that understand that there are some medications that are compatible with breastfeeding and with pregnancy and postpartum periods, and they don't have to exclude each other. What are some evidence-based models? We know cognitive behavioral therapy works very well with our Latinx community, and it has to do with changing that negative cognition schemas and replacing and exploring those negative thoughts and changes in behavior. The interpersonal psychotherapy is also an evidence-based model for perinatal mood and anxiety disorders. It's a specific treatment with specific timeline and it includes the families and the relationships. So it could be very helpful with this community. And acceptance and commitment therapy and learning mindfulness exercises also is evidence-based for this population. We should always take a trauma-informed approach and understand that our treatment should be person-centered, understand that healing takes time and needs connection, and always look for the strengths. We all have strengths, even in the hardest of times. So we always need to look for that and highlight those with our clients. What are some of the pillars of intervention? So in perinatal mood and anxiety disorders, we talk a lot about holding and holding that space for the mom in an empathic and supportive environment. We talk about authenticity and always being curious and asking and being transparent. So there we also need to look at our own values and understanding and expectations of motherhood and parenting, and what does that mean to us as providers. And we talk about mothering the mother, being there for her, holding the space for her and her family in these times. Treatment plans should always be individualized, and we should be able to work with our team of psychiatrists, doula, midwives, whoever's working with the mom also. And one thing that works very well with our Latinx community is la receta or prescription, to have them something that they can take away from counseling, right? So we can have our own little pad and write down what the prescription is to encourage stress management and coping skills, to encourage her nutritional needs and physical well-being, as well as sleep hygiene and movement or exercise, and the social and practical supports that we all need, and reinforcing their strengths. These are some common themes that usually come up with this population and the work with perinatal mood and anxiety disorders. Talking about the birth story, very important. They might need, depending on what happened, they might need more time to work on that birth story, but we need to create space and ask about that birth story. I mean, it's a birthing it happens in an altered state of consciousness. So we need to be able to make a coherent narrative of what happens to us during that time and what that means. It's very important. The parental role transition, and these are themes that should be brought up in counseling. Grief and loss, and that doesn't always mean when a baby dies, but also all the losses that we have when we become a parent. You know, we lose time, privacy, just to name a few, and what that means and how to make sense of all that. It's very important when there's time. The communication and communication skills, especially with the partners specifically and within the family. And feeding alternatives and bondings are usually areas that there are concerns and they need information and just validation that that's going well. So I want to keep with time. These are some resources. Postpartum Support International has a Spanish telephone support line, and also right now during COVID are having a lot of virtual meetings. They have every Tuesdays or maybe one every other Tuesday for support on moms, but you can look into the dates, and it's they meet virtually and in Spanish for new moms, and you can look at their information in postpartum.net. They also have a provider directory if you need to refer to specialized treatment. It's important to do so. And these are other resources where you can find information that could be very helpful. Also, the Postpartum Stress Center from Karen Kleinman has great information and books, like the one the health, like Good Moms Have Scary Thoughts that I mentioned before, as well as other books that she has that could be helpful for working with this population. So before we get into the questions and answers section, I really want to thank you for your attention and want to remind you that when we pay attention to the beginning of the story, we can change the rest of the story. And for me, that's one of the biggest things of this work is that we can really make a change for the future when we take care of the wellness and mental health of the parents. We're impacting more than one generation. And that's, I think, very important and preventive work. So with that, I'm gonna leave it for questions and answers.
Excellent. Thank you, Marianela. Cindy is with us, and she will be helping us with the questions and remind everybody that they can put on their questions on their sidebar. There's a link, there's a tab with questions, and you can enter them in that part.
Do I need to do anything here, Angel?
You can just leave it at that slide, and Cindy will help the questions.
Okay, great.
Thank you, Angel, and thank you for a great webinar. We do have a couple of questions, so I'm going to start with them. The first one says, are there any studies that have shown that support groups for PP depression and anxiety are more effective for our Latinx communities than the typical individual counseling? And then there are more questions within that one, but I just want to give you time to like address each part.
Yes, that study that I mentioned from Lara Sinisomo specifically looks at how just family and after family, they offer support groups and groups like home visiting programs, for example. It works best, and it seems like it's what they prefer, Latinx, more than the one-on-one.
Awesome. And then on that same questions, they ask, due to the cultural values, is it more helpful to bring the community together to discuss what this looks like and how to help each other?
Yes, yes. Yes, I think so. I think we need to have the general public understand and what this looks like, especially and if we're in therapy with our client, and bring in the family, who she lives with, because we need to educate them because they're the ones who are very close to her and who can see the differences, and they need to understand and not sabotage if she wants to talk about things that might not be in line with her cultural values. So it's very important to educate the community and have awareness in general. Yes.
Awesome, thank you for that. The next question says, what are some validated PPD screening tools? More specifically, are they standardized for use with the Latinx women?
Yes, so that's one that I presented in the slides, like the Edinburgh postnatal depression scale that's validated within the Latinx, and it's very friendly. It's self-administered, and it's a great screening tool. The same as with the PHQ-9. They're both validated for Latinx communities, and they're in Spanish.
Awesome. I don't know if anybody has any further questions. We haven't received any more questions. We do have feedback. They really like your presentation.
Good, great. I can't see anything, but great. Here's some references, and I think the references are going to be, is the PowerPoint going to be shared as well? Here's some references.
Yes, the participants can access the the references and the full PowerPoint in the handout section of their menu.
Okay, great.
If you could go back just one slide, that would be great.
Sure.
Thank
Here
you.
you go. Yes.
We appreciate everybody that has been with us today and that great feedback that we've been receiving for Dr. Rodriguez's presentation. We would like to remind you that your opinion, it is important to us, and it helps us to continue to provide free webinars and technical assistances throughout the nation to help those providers serving Hispanic and Latino populations. And you can do this through our evaluation, which we will be sharing in the next few days. And with the completion of this evaluation, you can also access your certificate of attendees. Once again, it is very important for us and for our grantees that we have your input on this matter. So feel free to share your experience with us in that evaluation, and we look forward to working with you in the future once again. Well, I think we don't have any further questions. Cindy, do we have any further questions? No, I think not. Cindy's just writing through here. So I think with that, we can get this to a close. And once again, thank you, Marianela, for a great presentation. And thank you to our audience for sticking with us through this webinar. Thank you. Have a great day.
Thank you. Bye.